Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. This current series focuses on consent. I hope you enjoy it. Welcome to today's podcast, which will be continuing our series on consent. So my name's Dr. Sam King, one of the medico-legal consultants at Medical Protection. And joining me again today is Dr. Lucy Gibbard and Dr. Tim Cookson. Welcome, guys.
Thanks, Sam.
Afternoon, Sam.
So in this particular case that we're going to discuss, I've entitled it, Are Your Clinical Notes Helping or Harming You? This case highlights some common issues across all surgical specialties. It just happens to be another gynae case. The patient had endometriosis and needed surgery, and the gynecologist, Dr. Jones, saw the patient in his private rooms. The patient, Mrs. Smith, had researched the possible treatments online and decided that she did not want an endometrial ablation, but was happy with endometrial excision. Dr. Jones had a discussion with Mrs. Smith about the risks and benefits of her options, both non-surgical and surgical, which he believed included ablation. And he gave us some information booklets to read. Unfortunately, Dr. Jones didn't document the discussion about the use of ablation or its risks and benefits in the clinical notes. At that appointment, Mrs. Jones was treated with the non-surgical options with a planned review in the future. At a subsequent appointment, Mrs. Smith came with her husband as the non-surgical options proved unsatisfactory. Both Mr. and Mrs. Smith advised the HDC that they had come away from that appointment stating they had clearly articulated that Mrs. Smith did not want an ablation. They recall being reassured by the surgeon that this would not be the case. Dr. Jones responded to the HDC that he had no recall of the patient stating they didn't want the ablation, and that it would be unusual to proceed with excision as the sole option. Unfortunately, there's nothing documented relating to this. Dr. Jones then referred the patient to the public hospital under their care for the operation. Lucy, what do you think was going on at these first two appointments with regards to just the communication going on?
Well, it's very hard to say, isn't it, Sam? Because as so often with HDC cases, there's a he said, she said aspect to this, where the patient and her husband remember one conversation and the doctor thinks that would be an unusual thing for him to have agreed to, but there's nothing documented. And that really makes it very difficult to actually say for sure what happened. Clearly, when a patient has come with a support person, you've then got two people saying what happened. And although those two people obviously probably have a vested interest in backing each other up, that becomes definitely a stronger position than a single person. But having said that, normally you would hope there were some notes whereby the doctor would have something to back their side of the story up. Unfortunately, in this case, if Dr. Jones hasn't written anything about discussing ablation or the pros and cons or the patient's concerns about ablation, well, then really he can't rely that he has done that. And the HDC are unlikely to consider that that happened, or will be at least very, very much less likely to take his side of that conversation, or of his memory of the conversation.
It's interesting, isn't it? Because often the HDC look at credibility with regards to the circumstances around the conversation when it happened and subsequently what does happen. And often they will make a judgment call around that. So it's pretty tough, I think, for clinicians when you haven't documented clearly. Often these things rest on a knife edge, which way the HDC will go. And I've certainly had that. I've also had some other cases where the HDC are uncertain they cannot make a decision. And I think that often that's probably the better thing. If you can't decide either way and it is purely one versus the other, he said, she said, how can you decide? You can't really, can you?
Mind you, in the past, the HDC has published that they regard it much more likely that the patient remembers accurately, because their argument is that, well, doctors see lots and lots of patients, and so they can't remember what happened in a particular consultation, whereas for the patient, that particular consultation was actually very important, and so they often have a much clearer memory. And so previous documentation from the commissioners have said that's why they prefer in general, the patient's statements rather than the doctor's, unless it's documented, as you say.
Mm. Although I'm sure all of us have seen complaint letters where the complainant is credible, but also where they don't sound particularly credible. And I suspect the HDC make similar judgments in terms of the way the complaint has been articulated.
But I think that the issue of whether or not there is any documentation on a point, just anything to say that that was discussed, would have been very helpful to Dr. Jones in this situation, because with nothing written, it's very hard to assure the HDC that those conversations happened when you've got no evidence for that.
I think that from what I understand, many clinicians in the hospital, when they're in a clinic, for example, particularly in private, tend to write notes after, or they dictate a letter to the GP after the consultation. They might write some very scant notes to, make note of what the blood pressure was, or, a particular reading. But otherwise, they tend to hold the history in their head until they get to dictate. And I think in that situation, it's possible that you miss details. Whereas GPs, I know, do tend to write contemporaneously as the patient is talking. But I think for specialists, in DHBs and in private clinics, it's actually very different. And so things can get missed quite easily. A common question I get asked is, do we clinicians have to document absolutely everything discussed? What would you say to that, Tim?
Oh, well, it's impossible, is the bottom line. But what you'd want to see is that the relevant and important things have been discussed. And if you think about it from the point of view of, say there's another clinician who's reading those notes and needs to know what happened, what are the guts of that consultation, what is the information that clinician could rely on as being sufficient? And that would include some often significant negatives as well as any positive type things that are stated. So in this case, yes, the documentation that she did not want ablation would have been a very useful thing to have recorded.
Lucy, do you think it's okay just to literally write risks and benefits discussed, tick?
No. In a word, I don't think that is sufficient. I think you've got to look at each individual case and actually look at the concerns of that patient. This patient obviously had a particular concern about ablation, and yet that was not documented. If he had just written down the risks and benefits, that still wouldn't have been documented. So I think often just writing risks and benefits discussed is a shorthand that doctors feel that they've documented the discussion, but actually it's really not sufficient. You actually need to talk about what was actually discussed with this particular patient, what were their particular concerns, what were their particular questions, and what risks and benefits were discussed.
I guess because it's routine often for the clinician, you're less likely to think, I need to document this, but it's not routine for the patient. And because we can't rely on our memory, we do need to document.
I think in this case, particularly because she's actually been referred to a public hospital, she's likely to be on a waiting list. There's likely to be a delay between that appointment and the surgery. All those things kind of add the risk that you actually won't remember when the patient comes along. And I think we all have had cases similar to this, where there has been something pertinent discussed in outpatients that gets missed when the patient actually comes in for surgery, and it's partly because of time, sometimes because it's a different clinician. But if you haven't documented what happened in outpatients, you're putting yourself and your colleagues at risk.
No, that's right. When Mrs. Smith finally came up to have her surgery in the public system, she was seen by the gynae house officer in the pre-op assessment clinic. According to Mrs. Smith, the house officer advised her that excision was planned because that was documented by the surgeon. The house officer thought it unlikely that they would have given this reassurance, although the consent form did state that the patient was having excision of endometriosis. The house officer also recorded in that particular pre-admit note wants excision, not ablation. The house officer would normally complete the consent form, but due to the patient's request, ask that the consent form be signed on the day of the procedure by the operating surgeon. On the day of the procedure, Dr. Brown, who was the registrar, met the patient for the first time. Dr. Brown hadn't reviewed the house officer's notes, as it wasn't usual for it to contain any operation instructions. Mr. Smith was present with his wife at that time and was very clear to the HDC that Dr. Brown was advised that no ablation was to be performed. The signed consent form stated excision and doesn't mention ablation. Dr. Brown obtained Mrs. Smith's signature on the consent form, and both Dr. Jones and Dr. Brown performed the surgery. Both ablation and excision were carried out. Lucy, what do you think are some of the hazards of patients starting in private and ending in the public system?
Well, it's always hard to know what notes are being transferred. Often clinic letters will be there and an admission note maybe, but maybe there will be information in private notes that actually won't be in the public hospital notes. So there's that risk of incomplete notes. Equally, that issue of communication between clinicians can be a problem in these situations. Particularly in this situation, the same doctor was involved in the surgery in private and public, but sometimes that's not the case. And if the patient is seen in private by one doctor and then operated on another in public, and the notes aren't complete, that can cause significant problems. Patients often assume that everything that they've said to one is available to the other. Patients often think that their GP notes are available to the hospital clinicians, and vice versa. So they often believe there's this kind of shared knowledge that isn't always real. So I think that is particularly exacerbated when the patient comes from private into public, when the notes often aren't transferred in their entirety.
Tim, it's not uncommon that the operating surgeon has never seen the patient prior to meeting them on the day of surgery. What do you think are the safeguards that these surgeons can put in place?
Well, I guess a surgeon needs to be sure that, first of all, that the surgery is indicated, so they've got to be happy that that's the right procedure for the right patient. And so obviously reading all the notes to reassure themselves of that would be the first major criteria. And then, as we've discussed, it's actually the operating surgeon who has primary responsibility for the consent process. So again, they need to go over the consent, make sure the patient doesn't have any questions, and ensure that that's all fine. It is really problematic, though, isn't it, that these surgeons who are going to be doing the operation only see the patient in the hour or so beforehand. And you really got to think, is there some other way? Now, it's not clearly practical for patients to be admitted 2 or 3 days beforehand because, with DHBs, the way they're organised, it's not going to work. But you do kind of wonder whether more use could be made of remote consultations, and that 3 or 4 days beforehand, that surgeon, they know they're going to be doing that list. They've got a list of the people that they're going to be operating on, and they ring those people, go through the consent. They can do final sort of confirmation on the day, but they could clearly do the majority of it remotely. So maybe something for DHBs to consider as part of their processes.
Lucy, who has responsibility for the consent here? Who do you think it bears the overall responsibility? Do you think it was Dr. Jones, who was the consultant who saw them in private, or Dr. Brown, the registrar, who signed the consent form with Mrs. Smith?
I think it's definitely a shared responsibility there. But I think as Tim says, it's the operating surgeon who has the onus on them to ensure that the patient has been properly consented. And from my understanding, the operating surgeon in this situation was Dr. Jones, was the consultant. And as such, it was his or her responsibility to ensure that patient was adequately consented. Especially in this case, since Dr. Jones had actually seen the patient in private and had got information from the patient that they were aware of. So I think that on the whole, the senior doctor operating would be expected to have made sure that the consent has been appropriately considered and appropriately documented. Having said that, I think Dr. Brown, as the registrar who was also operating and who actually did go through the consent with the patient, would definitely bear some responsibility there as well. So I'd say it's probably a shared responsibility, but probably more for the consultant or the senior doctor there.
And generally speaking, it's the consultant who carries
Yeah.
the can, isn't it?
Yeah.
If something goes wrong, although there may be some shared degree of sharing, the buck will stop with the consultant.
And in terms of the outcome of this case, I think the HDC is in agreement with you there. So Dr. Jones, the consultant, was found in breach of the code, Right 7, which states that every consumer has the right to refuse services and withdraw consent to services. The HDC said a surgeon needs to read the notes to the extent necessary to satisfy himself or herself that they have all the information that they, as the operating surgeon, needs to know. And the HDC goes on to say, I expect that this would include recently prepared documents completed for the purposes of the surgery. Furthermore, the onus is on the clinician to ask the relevant questions, examine the patient, and keep proper records. Only then is the clinician in a position to properly consider all the risks, review all available information, and then, and only then, proceed to perform the surgery. The HDC stated that Dr. Jones, as the treating practitioner, retained overall legal responsibility and accountability for the consent process. Ultimately, he performed a procedure on Mrs. Smith that she had not consented to. Dr. Jones was also found to have breached the Medical Council statement on medical records for not recording the information he provided to the patient and writing down her refusal of ablation. He didn't accurately record the procedure he intended to perform before being excision and or ablation. The HDC also made an adverse comment about Dr. Brown, the registrar, for not reading the notes prior to the operation. Although as Dr. Brown was assisting Dr. Jones in theatre, they might well have assumed that Dr. Jones would be aware of the patient's history, and I think that was a reasonable thing to have assumed. The DHB changed the standard to consent forms to include ablation. They also reviewed the process of the house officer doing the pre-admit clinic because it forms part of the consent process. So I think the Commissioner did agree with both you and you, Lucy, and Tim. So the learning points from this particular case: consent is a process. It starts when the patient first comes to clinic and doesn't end until the operation. It's really important to document it well. It helps to remind you of what has been discussed and also informs others involved in the patient's care, as Tim mentioned earlier. Please ensure that the consent form is clear and accurate. And had that happened in this case, then there wouldn't have been an HDC complaint. And the last learning point is to read the paperwork. I know that you're all very time poor, but a little bit of time spent reading the clinical notes ahead of time can save you and the patient an awful lot of stress.
In this situation, the house officer was actually placed in quite a difficult position because he was given information that was from the patient that was different to what he would have expected, as regards her not wanting the ablation. And I thought he actually made a really good decision to not complete the consent form, but to suggest that it should be the consultant who did that on the day of the procedure. And actually, you might have thought that change in the usual process might have alerted the consultant to think, actually, there's something here we need to look at in the notes that might be relevant. So that was an opportunity that was missed because of not reading the notes.
Yeah, that was interesting because it was the registrar who ended up signing the consent form, and rather than the consultant. Interestingly, and this is something that I didn't mention earlier, the HDC did make a comment about the house officer. They weren't criticised, but there was a suggestion made that the house officer, if it was an unusual situation where the patient has said, I want this bit, but I don't want that bit, that they ought to have contacted the SMO directly to let them know that there was a change or a variation. And, point taken, I think that would have been helpful, obviously, if the house officer had done that. But they weren't criticised per se. It was just a suggestion that was made. Thanks, Lucy and Tim, for your comments. And hopefully for those listening to this podcast, you've learned a couple of things that might help you in your clinical practice when it comes to consent, because certainly it isn't a very straightforward thing as much as we would like it to be. And there are lots of little pitfalls that you can fall into if you're not aware. So hopefully that you've learned something, and we'll see you for the next podcast. Thanks, Lucy. Thanks, Tim.
Thanks, Sam.
Thanks, Sam. And we look forward to hopefully you joining us for our next podcast.
Thank you for listening to this podcast. I hope it's been helpful. We look forward to catching up with you in our next podcast. If you like the Medical Protection podcasts, please subscribe and leave a review.